There are many physiological, metabolical, and psychological changes that occur in patients with burn injuries. Burn injuries can range from a sunburn to major burns involving all layers of the skin. Skin injuries can lead to inflammation and fluid loss, which changes affecting functions of the body systems. A patient that experiences burn injuries will need care ranging from temporary to an extensive length of time. This care will assist the patient to survive the injury, reduce their complications, and return him or her to their best functional status. After this lesson, you will be able to apply the principles of asepsis to protect burn patients with open wounds, manage the patient's environment to prevent infection in patients with burns, compare the manifestations of superficial, partial thickness, and full thickness burn injuries, prioritize nursing care for the patient during each phase of the burn injury, and be able to compare pain management strategies for patients in each phase of the burn injury. The etiology of burn injury includes dry heat, which includes open flames. This can consist of house fires, explosions, or ignited clothing. Moist heat, which could be scalding hot liquids that are spilled onto the person. Contact burns can be resulted from hot grease injuries, curling iron burns, space heaters, or floor heaters. Chemical burns can happen in the home or industry, such as the use of oven cleaners, rust removers, acids in bathroom cleaners, drain cleaners, disinfectants, and gasolines. One source of electrical burns is downed power lines. Electrical burns burn from the inside out, so the damage appears small on the outer surface, but the internal damage is significant. And then exposure to large doses of radioactive material can cause radiation burns. One such example would be nuclear plants. General care of the burn client will include thorough hand washing, protective isolation, such as sterile sheets, and the bed linens that are being used need to be changed frequently. Workers need to wear masks, gloves, head covers, gowns, plastic aprons, and shoe covers when caring for a patient with burns. Table 28-1 on page 513 of your textbook provides detailed information related to classification of burn depth. The severity of the burn is determined by how much of the body surface area is involved and the depth of the burn. We are now going to discuss the different depths of burn injury. Superficial thickness includes the epidermis only. It appears pink to red, has no blisters, can heal in 3 to 5 days, and some examples include sunburn or flash burns. The superficial partial thickness is the upper third of the dermis. It's pink to red, has blisters formations, and healing time is anywhere from 10 to 21 days. Deep partial thickness extends deeper into the dermis. Blister formation does not usually occur. There is no blistering because the dead tissue layer is so thick and it sticks to the underlying dermis that it does not lift up off the surface. The surface is red and dry. There are white areas in the deeper parts, and it blanched slowly or no blanching at all noted. Pain is less in deep partial thickness than in superficial burns because there are more nerve endings that have been destroyed. Full thickness burns includes destruction of the entire epidermis and dermis. It will require grafting because all the cells responsible for regrowth have been damaged. The eschar will appear hard, dry, and leathery and will have to come off. Severe edema accompanies these type of burns. Debridement is required for the healing to occur. When the injury is circumferential, blood flow is reduced and breathing can be impaired, especially if it's going around the chest. You want to check for breathing and distal pulses, and you may require an escharotomy or a fasciotomy of the patient. The burns may appear waxy white, deep red, yellow, brown, or black in color. Sensation will be absent, and healing time can take weeks to months. Deep, full-thickness burns extends into the fascia and tissues. It can damage muscles, bone, and tendons. It can occur with flame, electrical, or chemical burn injuries. It is blackened and depressed. Sensation is completely absent. It will require grafting and may possibly require amputation of an extremity. So let's check out some of the vascular changes. We are going to discuss fluid shift and fluid remobilization. During fluid shift, there will be third spacing. This is related to the occluded blood vessels. There will be hypovolemia. Fluid shift leads to cell damage, which equals metabolic acidosis. There will be hyperkalemia due to the release of potassium from the damaged cells. Hyponatremia occurs due to interstitial loss of sodium through the burn wound and dilution during the fluid administration. The increase in hematocrit levels equaling the vascular dehydration runs into hemoconcentration. So we want to restore fluid balance. Within 24 hours after injury, we need to initiate the fluid remobilization. We need to stop capillary leaks. There will be a diuretic stage between 48 and 72 hours afterwards. This will be interstitial to intravascular, and this is due to the capillary membrane integrity being restored. They may continue to experience hyponatremia due to renal excretion and through the wound loss. They will also experience hypokalemia. This is due to the potassium moving back into the cell. Protein continues to be lost from the wounds, adding to hypoproteinemia. Patients that experience burns will experience a decrease in carbon monoxide output. Gas exchange drops because of the fluid shifts, leading to carbon monoxide poisoning. And potentially circumferential chest burns. Chest burns restrict the ability to breathe. Inhaled smoke can cause airway edema and respiratory failure, which then increases the heart rate. Fluid resuscitation can increase carbon monoxide output, potentially promoting gas exchange. Clinical manifestations of pulmonary injuries can include the patient becoming progressively hoarse, developing a brassy cough. They may drool or have difficulty swallowing and can produce sounds on exhalation that includes audible wheezing, crowing, and/or stridor. Gastric mucosa is damaged due to the decreased GI blood flow. The mucosa normally protects against ulcers, but when it's damaged, you lose that protection. The sympathetic nervous system changes include the secretion of epi and norepinephrine. GI motility is inhibited, reducing the blood flow. Peristalsis decreases. The patient may experience paralytic ileus. They will have abdominal distension because of secretion and gases. They may end up with a Curling's ulcer, which is related to the decreased GI blood flow. We want to use H2 histamine blockers to prevent these changes. The metabolic changes include an increased metabolism related to the secretion of catecholamines, antidiuretic hormones, aldosterone, and cortisol. Patient will require oxygen and calorie needs, and these calorie needs are high due to catabolism. It will take 4 to 12 days after the burn to months after all wounds have actually closed. The phases of burn injury include the emergent phase, the acute phase, and the rehabilitative phase. Let's discuss the emergent phase. The emergent phase is the onset of injury up to 48 hours. We want to maintain an open airway, provide an adequate circulation via fluid replacement, keep the patient comfortable even if we use pain medications, prevent infections, maintain the patient's body temperature, and to provide the patient with emotional support. Okay, let's discuss the emergency phase if there's a direct airway injury for the respiratory. There will be carbon monoxide poisoning if you want to review on page 522 of your textbook, or if there's any other inhalation injury. You will provide 100% of oxygen via non-rebreather face mask, and this could be caused from smoke poisoning such as plastics or circumferential chest burns. You want to watch for pulmonary fluid overload that can happen 8 to 12 hours after beginning fluid resuscitation. That is on page 522 also. You want to keep emergency airway equipment near the bedside, and you may have to use paralytic agents such as bucking the ventilator. They still require sedation, analgesia, and anti-anxiety medications. So IV fluid resuscitation during the emergent phase is to help maintain blood flow to the vital organs. Burns that are larger than 35% total body surface area, you cannot use the urine output or vital signs to guide the fluid resuscitation. It's too insufficient. You may use urine output if the total body surface area is less than 35%. There is invasive monitoring of the cardiac and the pulmonary function that is necessary for fluid resuscitation. This invasive monitoring consists of central venous pressure, pulmonary artery pressures, and cardiac output. Central venous pressure is the direct measurement of the blood pressure in the right atrium and the vena cava. There is a double lumen line that is placed in the subclavian, and the catheter rests in the lower third of the superior vena cava. Normal central venous pressure is usually 2 to 6. Central venous pressure is elevated by overhydration, which increases the venous return, heart failure, or PA stenosis, which is limit venous outflow and lead to venous congestion, positive pressure breathing or straining. CVP decreases with hypovolemic shock from hemorrhage, fluid shift, dehydration, and negative pressure breathing, which occurs when the patient demonstrates retractions or mechanical negative pressure, which is sometimes used for high spinal cord injuries. Okay, shock is the most common cause of death in the emergent phase. They may experience hypovolemia. They're going to have the decreased cardiac output. Invasive blood pressure monitoring is needed. Digoxin is given to improve the left ventricular function and prevent pulmonary edema. In the renal and urinary system, the patient with burn injury will experience decreased renal blood flow, presence of cellular debris, highly concentrated urine with high specific gravity, and the potential for renal failure. And when discussing the gastrointestinal during the emergent phase, you want to assess bowel sounds. They may experience paralytic ileus, nausea and vomiting, abdominal distension, possibly an NG tube to prevent aspiration and remove secretions, and you will monitor OB stools for ulcer formation. On page 523 of your textbook, figure 28-11 depicts an image that assists in identifying the area and the percentage used for the skin assessment of a burn patient. You want to use the rules of 9. It is used when identifying the percentage of total body surface area of the injury. The size of burn is needed for diagnosis, prognosis, and calculating drug doses, and for fluid replacement volumes and caloric needs. We may use Silvadene if the patient is not allergic or has not had allergic reaction or does not have decreased white blood cell count. It is a sulfonamide. It kills bacteria by working on the cell membrane and the cell wall. Pain management will include opioid and non-opioid analgesics such as, but not limited to, morphine, Dilaudid, and fentanyl, and you only want to use moderate pain relief. You do not want to depress the respiratory function or reduce intestinal mobility. IV route is used best for absorption. The acute phase occurs 36 to 48 hours after the injury till the wound is closed. There will be a continued assessment and maintenance of all body systems. IV treatment is successful, you want to monitor output. You will check for debridement, and you will continue to care for the grafting site, provide nutritional requirements, and apply pressure dressings per protocol if ordered. The rehabilitative phase occurs when the wound has closed and they're at their highest level of functioning. This can be years to even a lifetime. They may have psychosocial issues. We need to know as an RN what we are allowed to delegate to the LPN or the nursing assistant. What is your responsibility as an RN? Your responsibility as the RN will include the plan of care to teach the patient and the family and to assess all outcomes and goals. This concludes the lesson of care of patients with burn injuries. If you have any questions related to the content of this lesson, contact the instructor.